All right. Welcome, everyone, to our webinar, the first of this year. We are going to be joined by Jessica Beltran to be talking about grade for multiple comparisons and more information about how to use the multiple comparisons evidence decision framework to help with guidelines that are comparing multiple interventions to one another. We'll have a 30 to 40 minute discussion from Jessica, and then we will open it up for question and answer. If you have any questions that come up during the talk, please feel free to put them in the chat, and we can make sure they get answered before the webinar is done. Some real quick housekeeping notes. So you can follow us, the US Grade Network and Evidence Foundation, on our Facebook page, facebook.com/USgrade, on our BlueSky and our Instagram accounts, as you can see on the slide here, to stay up to date about future webinars that we will be holding, as well as other educational events and opportunities. You can also view all of our previous webinars that are recorded on our YouTube page, and this one will be going up in the next week or two. This is a great way to kind of look through our page about previous webinars we've had, if there's any that are of interest to you. Finally, I want to make sure that everybody is aware that we are just 2 months away from our next in-person grade workshop. This is a 3-day workshop going over the grade framework for developing recommendations. And we are actually focusing for the first time on grade for multiple comparisons. So if you're joining today with an interest in that topic, the next step would be to join us for our workshop in Kansas City, May 18th to 20th. There are still spots available. You can go to www.gradeconf.org to learn more about it, see a typical agenda, and hopefully register and join us in May. We look forward to seeing you there. And with that, I'm going to introduce our speaker, Jessica Beltran. She holds a degree in medicine and a master's in epidemiological research from Universidad Cayetano Heredia in Peru. And she is currently pursuing a PhD in biomedical research methodology and public health at the Universitat Autónoma de Barcelona. She has expertise in public health research, health technology assessment, and clinical practice guideline development. And she works as a researcher at the Cochrane Iberoamericano Center and the GRADE Center in Barcelona. Her research focuses on evidence synthesis to support informed decision-making and the development of clinical guidelines. With that, I will hand it over to Jessica.
Hi, hello, good afternoon, everyone. I'm going to share my screen now to start the presentation. So,
that looks great.
Okay, perfect. So, today I will present the Grade Evidence to Decision Framework for Multiple Comparisons, a tool to make transparent, evidence-based recommendations when decision makers need to compare several options at the same time rather than just two or just pairwise comparison. So I have no actual or potential conflicts of interest related to this presentation. However, I am a member of the GRADE Working Group and a member of the GRADE Barcelona Center. This presentation is based on the recently published GRADE Guidance 45, which introduces updated guidance for the evidence decision framework in both pairwise and multiple comparison settings. So this workshop is actually very timely as this work has just been published this week. So why a new ETD framework for multiple comparisons? Is our key question today. It's because in practice, panels are rarely choosing between just an intervention A versus an intervention B anymore. They are often comparing a whole set of alternatives. So the Grade Evidence to Decision framework provides a structured approach for moving from evidence to decisions, but it was originally designed mainly for pairwise comparisons. So in a multiple comparison setting, that can mean that they need to populate as many ETD frameworks as comparisons. So that can be time consuming, burdensome, and actually very inefficient. So guideline decision making is becoming more complex. We increasingly need to evaluate multiple options at the same time, especially as systematic reviews now include network meta-analysis, and they're becoming more and more common. And it's important, but it's also important not to base our decisions only on effects. So even if we have a network meta-analysis, we need to look beyond this and to take into consideration other very relevant factors that are needed for decision making, such as what matters to patients, is the option feasible, is it acceptable, equitable, or even affordable. So then the purpose of the multiple comparison ETD framework is to evaluate all relevant options across key domains to help to manage complex evidence and to support consistent evidence-based decisions. It also incorporates newer grade guidance that has emerged since the original ETD framework was published. So what's new in the ETD for multiple comparison? So let's see, we are going to review today because of time. We can only focus on the key updates for setting up and assessing multiple comparisons. So in the next slides, we are going to summarize these updates. Let's have a closer look. So for example, in the new guidance now, we have suggested that before starting the assessment, panels need to agree on important foundations, on important thresholds or decisions that will set the rules for the rest of the assessment. These include the outcome prioritization, the values of setting the values for the outcomes, and definitions of thresholds. Then during the assessment, we have and now we have to also remember that this new framework is flexible to include different scenarios depending on where do we take the evidence of effect from. So for example, if we have a network meta-analysis, we can use this framework. But if a network meta-analysis is not available, then we can even use several systematic reviews that are assessing the medications or the interventions versus a common comparator. For example, anti-diabetic drugs versus placebo that were assessed in several different systematic reviews. Or we can even assess multiple comparisons that do not share a common comparator, but that panels still need to assess all this evidence to answer a given question during the guideline development process. And then the net effect. The net effect is one new criterion that we suggest to use. Here, we have to define how substantial or what is the relationship between the desirable and the undesirable effects. This was previously done by panels always, but in an implicit way. And now we suggest to explicit this. Then in the conclusion sections, we have the summary of judgments. The summary of judgments will summarize or will depict all the assessment that we have done previously during the assessment of across criteria using also the multiple judgment grids. So we are going to see these new features step by step to understand them. So let's begin with the question updates. So here, for example, we have the question section that includes a central question, whether and which of the multiple interventions are preferred for a given health problem and population. And then we specify the PICO components of this question. This includes a section for the population and then a section for the interventions. Here is where we can depict the scenarios. For example, if we have an NMA, we can list the interventions, and we can choose to show the results of the NMA versus a common comparator. And then we can also list here the several interventions with the common comparator. But if we don't have the common comparator, then here we can list the comparisons. In that way, we are flexible to incorporate all these scenarios that we frequently encounter. Then we include the outcomes, of course. The prioritization of the outcomes should follow the grade guidance as usual. And then we have to include here the outcome importance. In this example, we can see that they are reported as health utility values and health disutility values. This is one way, but the important thing is that the panels agree on the importance of each of the outcomes in advance. As well, we need to agree on the magnitude of effect thresholds before the assessment. So we have to decide what is a trivial, a small, a moderate, and a large effect. So these thresholds will help us make the judgments for several criteria, like the desirable effects, the undesirable effects, the net balance, the certainty of the evidence, the values, and the balance of effects. Now, let's look at the assessment. So remember that in the assessment, we already have several criteria that the previous ETD guidance suggested. So we suggest to keep all these criteria plus the net effect, but always remember that the ETD is flexible, meaning that different domains may require more or less emphasis depending on the question, the available evidence, or the context. So imagine that you have conducted an NMA, and this is your summary of findings. So it is a lot of information, right? But once we have the thresholds, then predefined, interpreting the results becomes much more easier. Like in this example, we have the azathioprine, and we have that the absolute effects are reported are 29 fewer deaths per 1,000 people. So because we know the thresholds, we can easily interpret that and say that the azathioprine has a small desirable effect. Then you can do this for all the interventions, and this summary of judgments, summary of findings can become easily this multiple judgment grid that is much more easier to interpret. So we can even semi-automatize this process to generate this multiple judgment grid, and this makes much more easier to make to reach an overall judgment. As in this example, we see that the azathioprine shows a small desirable effect on mortality, large desirable effects on preventing disability, and large desirable effects in reducing relapses. So based on this, most panel would likely judge the overall desirable effects as large. And then we follow the same process for the rest of the interventions. So now we are going to see the net effect. So the judgments in these categories range from large desirable effects to large net undesirable effects. And what this criterion does, it evaluates the relationship between desirable and undesirable health effects for each of the interventions and makes explicit an assessment that was typically done implicitly by the panels in the original ETD. So if we have a closer look on how to operationalize this, we see, for example, in the same drug that we have large desirable effects, and then we have trivial undesirable effects, and most likely most panels would agree that this is a large net desirable effect. Whereas we have the interferon beta 1b, with moderate desirable effects and small undesirable effects. So these can be interpreted as small net desirable effects. So the net effect, as you can see, is especially helpful in the context of multiple comparison questions because which involves a large quantity of data, because it helps interpreting the data in a more straightforward way. And also, this additional step provides more granularity and helps panels make clearer judgments about the balance of health effects. For example, here we have 3 interventions in this example for which the balance of effect was judged to favor the intervention in all cases. However, if we conduct an explicit net effect, we can see that the magnitude of effect differ across interventions. And we can see that the net effect is different between interventions. So the first one is a large net desirable, the second a small net desirable, and the third a moderate net desirable. So this overall greater granularity will help panels not only to judge better the balance of effects, but later to make a relative comparison across the interventions. So once we have completed the assessment for all the ETD criteria, judgments are all depicted in the summary of judgments. So this table is especially helpful in this context because here you can see there are several interventions. And here we are going to go a little bit more slowly to see the step by step. First, we have to determine the direction of each of the recommendations. For this, we can use the net effect and the balance of effect mainly, right? So if we have, for example, in the first column, the comparison A versus D, we see that we have a null trivial effect, a null or trivial net effect, and that the balance does not favor either. So in this case, the direction could be for either the intervention or the comparison. In the second case, we see a moderate net desirable effect, and we see that the balance favors the intervention. So here we can say that we can choose the direction for the intervention. In the next example, we see a null or trivial net effect, and we see that the balance does not favor either. So here we can also say that the direction is for either, right? In the next example, we see small net desirable and a balance of effects that probably favors the intervention. So here we can say that the direction is for or in favor of the intervention. In the next one, we see again a null or trivial effect, and then we see a balance that does not affect does not favor either. And in this case, we're going to see that the panel decided for the intervention, probably because of other factors. And then in the last one, we see a moderate net undesirable effect, and we see that the balance of effect favors the comparator. So we say that the direction is against the intervention. Now, we have to consider the certainty of the evidence to assess the strength of the recommendation. So, as you may know, if we have high or moderate certainty of evidence, then the strength of the recommendation would most likely will be strong. Whereas if we have low or very low certainty of the evidence of effect, the recommendation would be conditional. I mean, in the first case, it would be strong, and in this case, the last case would be conditional. So now let's see what happened in our summary of judgments. We see that the panel in the first case, before we had a direction that showed us that we could go for either. But here the panel has chosen as strong against the intervention category or recommendation. And this was based on the high certainty of the trivial benefit and because of a meaningful cost. Then in the second case, we see that the balance favors the intervention, as we see the moderate net desirable effect and the balance that favors the intervention. We see a high certainty of the evidence, and we see that the panel has voted for a strong recommendation in favor. In the third case, we see that there's low certainty, a neutral balance, and there's no strong economic or implementation differentiation between the criteria. So the panel decided that the recommendation was conditional for either. In this case, now we see that there's a favorable balance and a very low certainty of evidence and an economic advantage because we see moderate savings. So this is why there is a recommendation conditional for. In the next case, we see that there's a neutral clinical balance due to the null effect and the neutral balance of effect that does not favor either. But we see a strong economic advantage because of the large savings, and we see meaningful equity value trade-offs. So this was a conditional for. And in the last case, since the comparator was favored concerning harms, costs, and it was not acceptable or feasible, then it's a conditional against. So this is how the panel can reach each of the final decisions for each of the interventions using the multiple comparison summary of judgments. So as you can see, it's the same as in the pairwise ETD, but we are considering all the interventions simultaneously or sequentially, if you may want. Now, let's go to the conclusion sections of the ETD. So once we have this summary of judgments completed, we can group our final categories that are shown below. So we group them into two groups, the ones that are going to be recommended in favor and the ones that are going to be recommended against. Once we have these groups, we can, for those interventions that are going to be recommended in favor, we can even make a relative comparison among these interventions so that we can prioritize, or we can say which one is the most preferred to the least preferred interventions. To rank them or to prioritize them, we can even use graphical scores if it's considered easier or if it's desired. Then the recommendations have to follow this grouping that we've seen before, and they can even specify the ranking or the prioritization within the groups, as we can see here. So here we see that we have mainly conditional recommendations for the intervention, and we see in yellow that they have been prioritized in order from 1 to 6, and the recommendations follow this ranking, like in this example. This is another example of the of the ventilation for tuberculosis. In this example, what we see is that the balance of effects was similar across intervention. So it favored the intervention always. But we see that there is a difference, for example, in resource use and cost effectiveness that clearly favored the natural ventilation, thus giving them more stars, in this case, meaning that they were prioritized for each of these criteria. And then we see that it also increased equity, acceptability, and of course, it's feasible because it's natural ventilation. So we can see how using the stars, this intervention was prioritized or ranked in favor across the other interventions. Here, what we can see is that they had a favorable balance, moderate savings, economic advantage, and increased equity, acceptability, and feasibility. Here is another example of an ACP guideline where we can see the grouping, no, of the intervention. So after conducting all the assessment, interventions were grouped into the conditional recommendation against the intervention, into no recommendation group, the conditional recommendation for the intervention, the strong recommendation for the intervention. So once they had these groups, the recommendations followed this grouping so that the strong recommendation in favor of the intervention was described as recommendation type 1. But then the conditional recommendations were grouped into two groups depending on other factors, and they were described as recommendations type 2 or type 2A and type 2B. And then obviously the conditional recommendation against was in the group of the recommendations against. So these are examples of how the different groups have prioritize the interventions following this multiple comparison rate approach. So what are the key takeaways of this webinar? To conclude this multiple comparison, ETD framework is an approach that helps, it's a transparent and structured framework that facilitates decision-making process in a frequent but typically complex scenario that involves multiple interventions. So it structures a thorough assessment and judgments of all interventions across ETD criteria, facilitating the formulation of prioritized recommendations, as we have seen in the examples. And it structures relevant research data for multiple intervention questions, enabling the automate visualization of large data sets. So if you want to learn more, you can also go to one place where we can all have an excellent resource, that is the Great Book, for exploring these concepts in detail, particularly from the evidence to this decision section shown here, that offers practical and update guidance for applying these concepts in real decision-making contexts. Thank you very much. And then I am open for any questions and obviously to repeat anything that was not clear. Thank you.
Thank you so much, Jessica. Yes, lots of much deserved applause from the audience. I'm going to start with a question we have from Adrian in the chat. Adrian asks, are desirable and undesirable effects based only on absolute effect measurements?
Yes, because now if we go again to the Great Book, and we can see that the great approach now is focusing more on the absolute effects, not even to make this assessment, but also the certainty of the evidence assessment. So yes, because we are at the end of the day making decisions in our own context and decisions, health decisions, we need to use the absolute effects rather than the relative effects.
Great, thank you. Any other questions? Feel free to put them in the chat or unmute yourself if you'd like to ask one.
I'll ask a question.
Yes.
So Jessica, thank you for presenting. This was very helpful. So looking at the ETD is that you presented, essentially it's a table that has columns for the comparisons, and then you have the
Yes,
ETD domains, right? So that's really the main idea.
yes.
Now, in a lot of the networks that we deal with, there will be a lot of columns, right? So for example, if you have, let's say you have 10 interventions,
Mhm.
that means you have 10 times 9, that's 90 divided by 245. That would mean we have 45 columns, right?
Right.
So, which is crazy, right? So to make this really practical, so are you recommending that, let's say you have a network with 10 comparisons, so 40 with 10 interventions, so 45 comparisons, pairwise comparisons. Would a good approach be to pick the 4 or 5 of them that are most relevant to the
Um,
question, to the stakeholder, and just look at those?
well, I can tell you what other groups have done.
Hmm.
Let me stop sharing so I can see. I can tell you what other groups have done. Other groups, for example, have conducted the assessment until the net effect, for example. And once they see that they can choose the ones that have the most favorable net effect, then they stop there and they don't keep going for the assessment of the rest of the interventions. Because remember, the ETD needs to gather a systematic review evidence for each of the criteria, for each of the criterion, right? So most groups wouldn't conduct an economical evaluation, for example, or a systematic review and economical evaluation of those interventions that are not going to be favorable for the patient, right?
Hmm.
So once you have conducted your NMA and you have reached the net effect, you can select the best options by this time. I think this is what some groups have done.
What do you mean by the net effect? So if you have several outcomes,
Yes,
you
and
mean
then
that by the net effect, you mean just sub narrative or just in a non-mathematical way. You mean like
so
you, right?
so those interventions which their benefits outweigh the harms.
And as a judgment. Not you're
Yes.
not talking about actually calculating the net effect.
Well, what I can tell you is that, for example, in the examples that we have used in the annals of internal medicine that we have just published, we use the MS example from the MS Foundation, and what they did is they tried to assign a numerical value to each of the outcomes that was calculated using the utilities and the effect. So they did like a, let's say, like a weight for each
Hmm.
of
Yeah.
the outcomes results. And then they, to calculate the net effect, they did like a sum value,
Hmm.
assuming that the outcomes were not correlated and obviously not double counting the outcomes, right? So for example, if they had two similar outcomes that were measuring the same construct, they only picked one, no?
Hmm.
So they had this mathematical approach. So
Okay.
the net effect actually is the calculation of the net effect is it's a current project of the Great Working Group,
Hmm.
and they are developing different ways to calculate that.
Hmm. But most of the time, when we calculate the net effect, we just calculate it essentially doing a weight in our head, right? So
Yes,
we essentially look at the different outcomes and we'll say that the benefits are trivial for this, they are moderate for this, they are large for this, and then we come up with some sort of a net effect that's more of more based on a judgment, not really on
yes,
utilities and weight. So we'll say, okay, so you're saying that if we have a network that's very large, we
yes,
can do first this process where we look at the net benefit. Um, and choose the interventions where we think there's a net benefit, and then we would do the ETD for those.
yes, for
Yeah,
those, yes.
yeah.
Or if there are other criteria that you would like to choose to prioritize, for example, the cost, then that would also be
Yeah.
a value, right?
Yeah.
Depends on the
Otherwise,
state.
it's just a waste of time. Like it'll take a lot of time, and there's really no benefit. Like,
Yes.
so like just recall like a network meta-analysis we did on osteoporosis treatment. There was 19 treatments. So that means your pairwise comparison are 19 times 18 divided by 2, which is like 76 or something, right? So that's just
Yes.
not just that's a waste of time, and it just doesn't. You can't. Yeah, that's good. I think that's really for me the bottom line or the
Yes.
main message is to look at for the interventions where there's a good net benefit, and then for those, spend the effort on doing the ETD.
Yes.
Yeah.
But you are right that this approach is mainly a table to organize all the information. But it has
Yeah.
always been like this. So
Yeah, but I mean, it's a key message, I think, in any paper or in any
yes.
workshop is to say that you cannot have a 76 columns for the ATD. Like that's just, you have to pick the ones that are really either show net benefit or that the stakeholders are really interested in them. Because many times in a network meta-analysis, we really care about like one or two comparisons that are, that are in real practice. This is the question. This is the issue.
Yes.
Yeah.
Thank you for your question. Very
Yeah, sure.
interesting.
I mean, the difficulty is also if you can't trade it off one to one, as alluded earlier by Hassan and yourself, and once you have to have utilities come into play, and sometimes you have to, right? It's just not that we can take the thresholds and just trade them off directly. Um, then it gets more complicated. You have to find those utilities, and you have to
Mm-hmm.
not only find them, you have to also then sometimes
Yes.
critically appraise them and see whether you actually agree with them, because they can be all over the place. You have to figure out whether that's, a point or a year. And so
Mm-hmm.
that's quite a bit of challenge to that. So I want to make sure that folks
Yes.
understand that it
It is.
sounded like it could be
Yes.
automated, right? In that sense, but
Yes.
there's a lot of assumptions going into it and lots of difficulty actually finding all of that. So from a pragmatic perspective, I think it will be very difficult to pull this off, unless you put a lot of effort into this.
Mm-hmm.
Yes, but let's also remember that the the outcome importance cannot only be conducted or reported if you have utilities or these utilities, right? You can always use less, let's say, fancy ways to depict the importance, right? But at the end of the day, you do need to have a scale or a score, even though it's just a survey conducted to the panel. But this is very important before making the judgments, because all the panel members need to have a common understanding of what is each of the outcomes and how important are these for the patients, right? So yeah, I agree that utilities and disutilities require an additional systematic review. But then I think this is the best way to accomplish this.
There's also the assumption that the network meta-analysis has evaluated all the outcomes that you want. Most of the time, a network meta-analysis will look at like one or two outcomes, and then the other outcomes will be done not in a network meta-analysis. Like often adverse effects will be like reported, but you won't be able to do a network meta-analysis on them. So if you want to do a mathematical assessment of the net benefit, not only you need the utilities or some sort of a weight, but you also need to have network meta-analyses that looked at all your outcomes.
Yes, otherwise you can use like this is exactly what happened in the MS example that we published. They had conducted a network meta-analysis, but then they had to incorporate extra evidence, let's say, for the adverse events from trials that were conducted, like surveillance trials. But this is very important information as well, although it was not in the randomized control trials, coming from the randomized control trials. But they included this information, and they reported this in the ETD, so they had to use what they had. at hand, right?
Excellent. I think we saw somebody switching on the camera. Maybe there was an additional question. Okay, maybe not. Feel free to unmute yourself and just ask questions. It should be a conversation. This was a very interesting, thanks so much, Jessica. This was very interesting overview of multiple comparison, which is always going to be a challenge.
Yes.
In addition, obviously, what is it? This is not answering, and I just want to point this out, is sequencing, right? Where essentially there could be an order in which you actually are going to start the medication. And that is obviously not covered right now because that can sometimes also be important, right? So resistance development and so on that actually dictates a certain order of your intervention.
Well, they'll be in a network, right? Then there'll be the different sequences should be interventions in a network. Ideally, if you can do that.
Yeah, but there could be a temporal component to it, so that you wouldn't particularly. So if you, for example, if you have antiviral drugs, and you know that if a certain class of antiviral drugs would have a higher resistance development, in other words, you could use it in short-term scenarios, but not long-term scenarios. Then, but that drug is much cheaper.
Mhm.
Right? Then you might have to think about your sequencing. Is there any other questions?
That is true, and that was one of the observations that we received from the peer review, I remember. And the only way that we can now more or less tackle this is by showing the follow-up of each of the questions, in the summary of findings, and dividing maybe the outcomes in long and short term. But so far, this is the only way that we have managed with this time frame issue.
Okay, so the other, okay, we have another question here from Lelis Chukos. I have probably butchered his or her name. If I have a multiple comparison question and after conducting the ETD, it is concluded in favor of 3 different interventions that had varying levels of evidence certainty, how do I establish the certainty of evidence for the overall recommendation? Should I make separate recommendations?
Good question.
Yeah. Well, what the great approach recommends is to make separate recommendations due to the certainty of the evidence. So as I said, recommendations with high or moderate certainty of the evidence would be strong recommendations, so they can be in that group. And then if they have low or very low recommendations, then they most likely be a conditional recommendation. So yeah, the certainty obviously divides the recommendations in at least 2 large groups.
Mm-hmm.
Well, so, yeah, I mean, there's also the additional factor of the effect size, right? So potentially, if it's closely balanced, you might not be wanting to, recommend it, even if the certainty is high. So
I think it's possible to go on 2 levels. So first you make a recommendation for individual interventions, and then if you see that you have several treatments that have similar recommendations and similar certainty, maybe you can recommend them together and have a higher level recommendation. Say, we recommend A and B and C, for example.
Yes.
There's another question. I forgot to ask, are ETD for multiple concurrence already available in Grade Pro?
Yes.
Thank you for a great presentation.
Yes, it is. I think, I'm not sure if it's a beta version or already a formal version, a launched version, but definitely it's available in Grade Pro. So if within your Grade Pro you don't have access, you have to write them and ask for the access to the module. It's called the multiple comparison module. So you typically can find this in the blue bar at the left of the Grade Pro. So when you see where to complete the summary of findings, the ETD, so in this column, you can find the multiple comparison module. And they even have a new module for network meta-analysis data.
May I ask a question, Jessica?
Of course.
And I would also, maybe Hassan, because you also mentioned something related to this. So first, thank you, Jessica. This has been really nice. Thank you, and interesting. So I want to ask, so you suggested that at the end, we come up with one recommendation per one comparison.
No,
And that
no.
I'm sorry, go ahead.
No, what we suggest is to do a recommendation by groups, right? So if you have all the recommendations, all the interventions that are four and strong four, then you do one group recommendation for this group. But if within these groups there is a possibility to prioritize or to rank the interventions, then you can even do like a next level of recommendations and say which one within these groups are going to be prioritized. And different groups have done different things. They have said 1, 2, 3, 4, 5, 6. They have used stars, a recommendation level A, level 2, 2A, 2B, like this, you know?
Yes. Okay. That makes sense, but because we did something similar to this, and it was very hard to, even when you group the comparisons that are like, let's say 4, it was so hard because they usually they had different strengths. They had, and even sometimes the effect does not make sense. Like in one comparison, A was found better than B. The second one, let's say B was found better than C, and then C was found better than A. So
Yeah.
how will we come up? So we have different levels of uncertainties here. So, and even when you want to draft a recommendation, like we are all used to this structured, like the panel suggests or recommends this versus that. So we are very used to this structure. So when you come to the rank, what would you tell what would you say? Would you say the panel suggests or recommends, given that you have different levels of the strengths of the comparisons within? What would you say recommends using these drugs in this order? It was really hard for us to make kind of judgment. It was so hard.
Yes.
Yeah, it is hard for sure, Laura. I think what we said that what made most sense is to make a recommendation, different recommendation for each pairwise comparison first, as a first level. And then if you see that some things can be clustered, that they have similar direction, similar strength, similar effect size, then maybe you can cluster certain things together. Like you can say, we recommend A and B and C over standard of care. But you may be in a situation where you can't, like what you're saying. I think what Lara is saying, that she had a situation where the recommendation for individual pairwise comparisons were just different in magnitude and direction and certainty. So yeah, in that case, you may not be able to put them in buckets and come up with that second level recommendation.
And the end user, they want to know, like the clinical question was, what is the best drug? That's the clinical question. So how will they answer this? It was really hard. And to be honest, with everything that's going on, we are trying to estimate the capacity we have. If we're gonna invest our time and efforts and resources in doing such a big multiple comparison question, and then when we reach to the recommendation level, we cannot make this kind of statement like we recommend this drug, then that drug, then that drug, in this order. We are being questioned. Was this worth it?
Yeah, I hope we're not giving the message that this is easy, and we're not giving the message that this is settled. Like this is how you do it. This is evolving, and I mean, all these experiments, like the ones that Jessica mentioned, there's just like one network meta-analysis that was done into a guideline. They followed grade, and like these are small, very small number of experiments. So it's an evolving approach, and it's not easy.
Yeah, but
Yeah,
it's promising.
I really want to echo that. So it can become very critical if you, let's say, you're running a large health system and you are seeing that one area, let's say inflammatory bowel disease, is consuming a large proportion of your funds, right?
Mhm.
And you really need to figure out how you can steer frontline clinicians to the most effective drug that is also affordable or at least cost effective, right? And so that is obviously the biggest challenge here. So your perspective may vary depending on your setting when you create those guidelines, whether you are creating this in a institutional setting, whether you're creating this in a society setting, whether you're creating this in a government level on policy, these things will vary. And so our webinars are supposed to sort of figure out how we can cover and give some guidance on a variety of healthcare settings to be able to tackle that issue. And again, as Hassan pointed out, this is not something where we say, this is the only way to do it, right? But point out, excuse me, some samples, some examples where this was, a novel approach and where we would like the academic discussion to occur to say what are the advantages of such an approach, what's the disadvantages, right? So, for example, one disadvantage would be if you only look at sort of a network and you don't look at whether you should use those drug against doing nothing, for example, right? Is that you may not actually start out with a cost effectiveness that compares against nothing, which potentially could already be not cost effective, right? And then you're only doing like incremental cost effectiveness ratios, and then you see that they're all great because they're just a couple $1,000s more. But in the end, the entire burden on the health system could be substantial. So you have to sort of figure out from the start, and when you set up your scope, what is it what you would like to achieve? And yes, it's very easy to get, lost in the forest and not see the trees. I mean, it's very easy to do, that's for sure.
Yes, I just wanted to point it out two things. One is that, as Hassan said, this is an evolving approach, and we've just published like the first compilation, let's say, of all the experiences that have been achieved so far. And of course, there are a lot of limitations and difficulties in completing this whole approach on the one hand, but then on the other hand, for some scenarios, the alternative is to approach each question one by one. And then this has also the risk that we are like cherry picking the picos that we want to choose for our assessments beforehand, right? Instead of looking for the whole picture and selecting all the alternatives that are available for our patients. And sometimes this can be driven by political issues and other things, or economical issues, and not in the right way that should be like the, let's say, the methodological approach of looking at the whole picture and assessing all the relevant interventions simultaneously. Although it is, I am aware that it is very difficult to, at the end of the day, say this is the best drug. So this question is very difficult to answer. So just over, that's all.
Fantastic. Any other questions? We have time for one more. If not, I've placed a link in the chat if you want to learn more about our 3-day workshop coming up in May in Kansas City, our grade guideline development workshop with a focus on multiple comparisons. So thank you once again, Jessica, for a wonderful presentation. I can
Thank you for
tell,
the
you know,
invitation. Thank
yeah,
you very much.
absolutely. Given by the quality of the questions, it was obviously very effective. And I think a lot of people were very interested. So thank you all so much for joining us today. And we look forward to seeing you in the next one. Thank you.
Thank you.